All right, hello everyone. My name is Genevieve Glass. I am a reporter here at Being Patient, and today we are joined by Dr. Michael Geschwind, who is the professor of neurology and at the Memory and Aging Center at University of California, San Francisco. And we are going to be talking about rapidly progressive dementias, or otherwise known as RPD. So they're dementias that progress quickly, typically over the course of weeks to months, but sometimes it could be a couple years. And I think it's something that isn't talked about as much as dementia or Alzheimer's because it's not as prevalent. It's actually quite rare and it can be difficult to diagnose. So we are going to dive in with him. Thank you so much for joining us.
My pleasure.
Great. I just want to make sure that people can see you here. Hold on just one second. There we go. Okay, great. So I guess firstly, I'd like to start with, in your own words, what are rapidly progressive dementias?
Yes, Deborah, it's a great question. So there is no set definition for a rapidly progressive dementia or RPD, as you noted. I usually use the definition of a person going from normal cognition to dementia in less than 2 years. And usually it's much less than that. Usually it's less than a year, and usually it's a matter of weeks to months from normal cognitive function to dementia. And then I define dementia as somebody who's impaired in one or more cognitive domains. Cognitive domains could be memory, language, visual spatial function, executive function, organizing, planning, multitasking. Any of those domains sufficient that they can no longer function the way they could prior to the onset of the condition. So there has to be functional impairment due to cognitive dysfunction. And usually it occurs over weeks to months, but I extend it up to 2 years. And one of the reasons I use the 2-year cutoff is that prion diseases, which we'll talk about later, are probably the prototypical form of rapidly progressive dementia. And although most of the patients with prion disease survive, the total survival is less than a year from onset, let alone onset to dementia, which is much shorter. We do have patients who sometimes have a slower course of prion disease, and they may not develop full dementia until up to 2 years or sometimes even longer. So I wanted to capture that group. But the vast majority of RPDs, we're usually talking about somebody who has less than a year from onset of symptoms to development of functional impairment due to cognitive dysfunction.
Understood. Well, that was a great kind of overall view. Thank you. So what would you say is the overall prevalence of RPD in the US?
Unknown. At our center, we're a center specializing in cognitive impairment, dementia. We also see a lot of movement disorders, usually associated with cognitive impairment. We found that about 2.5 to 3, somewhere between 2 and 3% of all the cases referred to us with cognitive impairment, 2 to 3% of them were actually rapidly progressive.
Wow. Okay. And why, this is a question that we just got, but why does it progress so quickly?
Yes, that's a great question. And it's sort of the answer is sort of a reverse. It's the types of conditions that cause rapidly progressive dementia that explain why they present more rapidly. So I hope I'm not skipping ahead too much, but I tend to categorize rapidly progressive dementias into different etiologies, different causes based on underlying cause or pathology. So I use a mnemonic to help me think through all the different possible causes. And the mnemonic I like is one called vitamins, where each letter of the word vitamins refers to a different etiologic cause. So V for vascular, I for, and vascular could be strokes, vasculitis, where you have inflammation of the blood vessels, sort of anything, blood clots, like we're in COVID now, and there are patients who are developing blood clots in the brain, and that would be a cause. So a thrombosis, a clotting, abnormal clotting of the blood in the sagittal vein.
Apologies, that was my phone.
Yeah.
Sorry about that.
A clotting of the blood vessels in the brain can be caused by, in this case, post-vax from COVID itself, possibly from vaccination. So medication sometimes can do it. Certain bodily states like pregnancy can lead to hypercoagulation. Cancer can lead to hypercoagulation or increased clotting. So those are just some vascular causes. I for infectious, I won't go through all those. COVID-19, the coronavirus would be one possible example. Usually the COVID-19 doesn't directly affect the brain. It's very, very rare that they found the virus in the brain. Very rare. It's usually through secondary effects that you get neurologic involvement. But herpes encephalitis, Lyme disease, HIV, all of those can affect the brain. And then the T would be for toxic metabolic, so vitamin excess, vitamin deficiencies, disorders of nutrition can sometimes lead to that. So that would be a metabolic, different drugs of abuse, different drugs of not abuse, but drugs that you're given to treat something sometimes have side effects. So those would be toxic effects. And then the next, so you have VITA. The A is for, I use for autoimmune, usually antibody-mediated etiologies. And sometimes these antibodies occur spontaneously. Sometimes they're the body's reaction to fighting off a cancer. And those antibodies accidentally cross-react, not only attacking the cancer, but also attacking the brain or the nervous system. And then next would be M. I use M for a couple of things. Mitochondrial disease. The mitochondria are the energy or the building blocks of the cell. And the disorders of mitochondria, often through genetic mutations in one's mitochondrial DNA or one's regular nuclear DNA. We have two different sources of main DNA in the body. The ones we normally think of, the Human Genome Project, is looking at cellular DNA. But within each cell, there are these energy producers of the cell, these organelles called mitochondria, which originally, historically came from bacteria. And when we were much smaller organisms, mitochondria evolved and became part of the cell. And those have their own DNA. And sometimes mitochondrial DNA itself can lead to neurologic disease. And then metastases, if somebody has a cancer and it spreads sometimes to the brain, that would be another M for the in the vitamins mnemonic. And then another I in vitamins is iatrogenic. So usually caused by medical intervention. Usually it's medications that cause it. Chemotherapy, for example, can sometimes have side effects that can lead to rapidly progressive dementia. Radiation therapy as well. And then the next is neurodegenerative, and I'll use it for neurodegenerative, for neoplasm, neoplasm being cancer, either directly invading the brain or affecting the brain, or through maybe an antibody-mediated process. And then the last letter of the S, I use for a couple of things. Seizures, so sometimes patients can have seizures and they're non-motor seizures, so they're not obvious. Maybe to a trained clinician, they might see a little bit of twitching. The patient stares off into space, isn't really aware, isn't communicating, and we'll see a little bit of twitching at one corner of the mouth, and that could indicate that there's a non-motor seizure going on that's affecting the patient's awareness and cognition. And then the other thing that S can be would be systemic disease, sometimes autoimmune, rheumatologic, cardiac diseases, diseases of the liver. Systemic diseases can lead to dysfunction in the brain. Often it might be through a metabolic toxic process, sometimes through other processes. And then the other thing I use for S are structural. So sometimes there can be structural changes in the brain, such as maybe a mass, maybe a tumor, maybe not a tumor, such as a cyst, that actually are interfering with the flow of spinal fluid or are growing large and impinging on part of the brain. Sometimes one can have a leak of the spinal fluid, a CSF leak. That can often happen through somebody who overexerts themselves or has trauma. And that CSF leak can cause the brain to sink because the spinal fluid that's buoying the brain and keeping it up there, floating, if that spinal fluid leaks, the brain can sag and it pulls down on the veins and the nerves that are connected to the brain, and it can compress the top of the spinal cord, the brainstem, and all those things can lead to the brain not working properly. And sometimes that can be a form of rapidly progressive dementia. So I don't even remember what the initial question was. But
no, you answered it. So I mean, kind of, now thinking about what you just said, what are the symptoms? Are they similar to Alzheimer's and dementia? What are the commonalities and differences?
Great question. So I would think of it as a Venn diagram where you have two circles overlapping, and the overlap would be extraordinary. So the symptoms alone don't usually differentiate rapidly progressive dementia from other dementias. It's the time course. It's the time course of the presentation of those symptoms. So all the symptoms you see in a slower dementia, an Alzheimer's disease, where you have episodic memory loss, and later on in the disease, distant memory loss, long-term memory loss. Parkinson's disease, where you have motor dysfunction. Frontotemporal dementia, where you have a lot of behavior, personality changes. Huntington's disease, where you have abnormal increased movements, as opposed to Parkinson's, where you have slow movements. In Huntington's, you often have increased excess movements, fast movements. All of these things can occur in rapidly progressive dementia, but the time course, the evolution of the onset of these symptoms is faster. And that's usually what would tell somebody, this isn't a normal dementia, this is rapidly progressive. And it's important to know that because there is, like that Venn diagram, there's a similar workup or differential, but there are things that normally you wouldn't think of for a slow dementia. Right. So for instance, somebody has a lot of strokes or has inflammation in the brain causing strokes, that could lead to a rapid dementia. If somebody has a clot in the brain and the sinuses that drain the blood from the brain, that can lead to rapidly progressive dementia, but not usually a slower dementia. Usually it would be more quicker onset. Sometimes you have something called a fistula. It's where two sources that normally are kept separate in the brain, usually liquid sources, but two areas that are usually separate, a fistula abnormally connects them. So a fistula would be, you have the veins and the arteries are separate, but sometimes those veins and arteries can abnormally be fused together, and you have the venous blood and the arterial blood mixing, and that could lead to problems, particularly if it's in the brain. Yeah.
So kind of going off of that, I mean, you've given, a large array of ways that rapidly progressive dementia can occur. Is there a way that you can rapidly, reverse symptoms if you catch them early?
And that's why that question is so important, because that's what sometimes differentiates RPD from regular dementia. Many of the RPDs, not all of them, many of them are completely reversible, or at least treatable, if not, some are curable, and some are just where some you can at least stop it from progressing. So, and it really depends on the category. So the vascular causes, if there are strokes, you can intervene to stop the strokes. Some of the damage might be done, it might be hard to recover from. If it's a clot in the brain, if you catch it early enough, those are usually 100% curable and reversible. If you have inflammation of the vessels in the brain, often very reversible. Autoimmune causes, depending on the type of antibody and whether there's a cancer associated with it or not, those can be highly treatable, very curable, and even if not curable, a long life. Somebody can have a long life if you treat it effectively. Common things being common, one of the most common causes of rapidly progressive dementia are atypical presentations of other neurodegenerative diseases. So that's that N in vitamins. That's one of the N, one of the terms you can use for the N. And that would be other neurodegenerative diseases. So Alzheimer's disease rarely presents as rapidly progressive dementia, but Alzheimer's is really common. So it's pretty, so if you look at the numbers of patients who have an atypically fast presentation of Alzheimer's, that would be a large portion of RPD, because Alzheimer's is so common. Even though, if we have 5 million patients with Alzheimer's disease, if you're talking a small percentage of that, or even a fraction of percent, that's still a lot of patients with a rapid form of Alzheimer's disease every year in the United States. So atypical presentation of a normally or typically slower dementia would be a pretty common cause. Now, those, we don't have any treatments for those neurodegenerative diseases. Prion disease, CJD, that's also a neurodegenerative disease. Some people class it as an infectious because it is transmissible, but it's not transmissible. It's very hard to transmit. You have to take the abnormal protein from one person's brain, essentially put it into another's, usually through a neurosurgical procedure or other type of transplant procedure, which is uncommon. So it's not infectious like COVID or HIV by blood or hepatitis by blood. It's much harder to transmit. But those neurodegenerative diseases, we don't have any cures for any of them right now. We're getting there, but none of them are curative. Right. But it still would help us to know that this patient has a neurodegenerative disease such as Alzheimer's or CJD or Parkinson's, because then we can at least put them into the right treatment trial and we can help prognosticate. We can help the physician, the family, the patient know what their expected time course might be, what medications might help, what to expect over time, and how to alleviate the symptoms that arise.
Yeah, and so kind of going off of that, what is the most common type of RPD? It
depends on geography to some extent. So we've published papers on this, and I've published papers where I have charts of looking at different cohorts of RPD from around the world. And one thing that we noticed is that, well, two things, geography and time. So over the past 10 to 20 years, there's been a huge increase in our awareness of these autoimmune antibody-mediated causes of rapidly progressive dementia. The laboratories of Joseph Dalmo at Penn in Barcelona, Angela Vincent, Suraj Irani at Oxford, Sean Piddock, Van der Lennen and colleagues at Mayo. These three centers have really changed our understanding, expanded our understanding of autoimmune antibody causes of dementia or encephalopathy. And if you look at more recent studies, therefore, autoimmune is much higher than even sometimes neurodegenerative disease. If you look at the lesser developed world, such countries, maybe Brazil, India, they've published some very nice cohorts of rapidly progressive dementia. And in their studies, infection is among the highest, whereas in the European, North American studies, infection is much lower cause of RPD. So geography and time has has changed those. But I would say the most common causes would be other neurodegenerative diseases, autoimmune, infection in the developing world. Prion disease would certainly be the highest in most of the developed world. Europe, North America, Asia, many parts of Asia, Oceania, those areas, CJD would still be among the highest.
And what are the symptoms of prions?
Prion disease, I call it the great mimicker, because CJD, or Creutzfeldt-Jakob disease, which is the predominant form of human prion disease, can look like anything. The many different parts of the brain can be involved. And depending upon where the disease starts, that's how the patient may present. If the disease starts in the visual processing parts of the brain, patient might have visual symptoms. If it starts in the hippocampus, they might have short-term memory problems. If it starts in the parietal lobe, particularly the right parietal, they might have visual spatial processing problems. If it starts in the frontal lobes, they might have behavior, personality, executive function changes. If it starts in the cerebellum or areas of the brain that have connections to the cerebellum, they might have uncoordination, ataxia of limbs or of the body or gait. So it's really the great mimicker. I had one patient who, her first symptom was complaining that she lost her own autobiographical memory. She couldn't remember parts of her own life. And this was 20 years ago. And she went right to the psychiatric ward. And then about a week later, she started to develop other symptoms that made us realize this was a neurologic problem, not psychiatric. And at that point, we did a brain MRI and we saw the classic features for Creutzfeldt-Jakob disease. And we had our diagnosis. And unfortunately, she died within a few weeks. And her autopsy showed prion disease, Creutzfeldt-Jakob disease.
Wow. So what is the overall, from diagnosis, what is the overall lifespan?
Well, it's very varied. So
yeah, I feel like all of this is so variable.
Yeah. So
yeah.
Well, let's talk CJD, for example.
Yeah.
The shortest I've seen is 2 weeks from onset to death.
Oh
I've followed other patients for 8 years with CJD. Now, the last probably 6 years of their life was in a pretty much a persistent vegetative state. It wasn't a quality of life. But it took 2 years to get to the point where they were at that. So I had a patient who we diagnosed him 2 years into his illness. He had a language disorder and not much else. And he ended up living for another whole year. 3 years into his course, he was still driving. I'd taken away his license, but he's still driving. And then he had a rapidly progressive decline after that at the 3-year time point and passed away 2 weeks later. So the course can be quite varied. Typically for CJD in the literature, the median survival is about 4 to 7 months. So about half the patients will live less than that, half will live longer than that. 90% of patients in the literature live less than a year. In my own cohort, I find it's a little longer. About most patients will live, 90% probably would be less than a year and a half.
Oh my gosh. Wow. That's pretty shocking.
It's quick. It can be very quick. And that's why it's really important to make a diagnosis quickly and correctly, because you don't want to give somebody the wrong diagnosis if it's in fact something treatable or reversible if you catch it quickly enough. So you don't want to tell somebody they have CJD when they have a treatable autoimmune disorder, which is why there are things that can help us differentiate between these diseases. So it takes clinical experience, but often we can tell there are certain features that are more common in CJD and less common in autoimmune diseases and vice versa. There are certain findings in the CSF that might support one disease and not another. There are MRI findings that support one type of condition and not another. So the clinical story, certain blood tests, spinal fluid tests, brain MRI, those could all be helpful in helping us differentiate and better diagnose a patient with a rapidly progressive dementia.
And so talking about diagnosis, obviously from what you're telling me, it's extremely difficult to diagnose, but if you were speaking to someone who either themselves or a loved one is going through experiencing some of these symptoms and they're kind of a bit lost, what would you say is their first step? Was there a specific doctor that they should they go and see a neurologist immediately? Should they get a MRI? What are the steps?
Well, I think being seen by a neurologist first, and particularly somebody who specializes in cognitive neurology or behavioral neurology, that would be my first recommendation. Sometimes it can be hard to see a behavioral neurologist because there aren't that many of us. So at least seeing a neurologist would be helpful. But usually you want to first be evaluated by a primary care physician. They need to make sure that common causes of cognitive decline, which would include a blood test to make sure there's not an obvious infection, a systemic infection. So doing some blood tests, looking for liver function, looking at electrolytes, looking at a complete blood panel, and then maybe a urinalysis, making sure there's not a pneumonia, particularly in an elderly person. One of the most common causes of rapid decline, I don't classify it as a rapidly progressive dementia, but a rapid decline in an older person is somebody who has some underlying neurodegenerative disease, let's say early Alzheimer's or Parkinson's, and then they have a metabolic disturbance, usually through an infection, a pneumonia or urinary tract infection, and all of a sudden they have a steep decline. I don't consider that a rapidly progressive dementia because the whole disease course was much longer. They had symptoms of Alzheimer's or Parkinson's for maybe years before, and now they have a sudden steep decline. So the first thing is to make sure there's not something metabolic going on that's causing a rapid decline in a person who's more susceptible to that, an older person, a person with an underlying, more slowly progressive neurodegenerative disease.
And so can RPD occur at any age, presumably, if you have an underlying condition?
Yes, they can occur at any age. Some of the autoimmune causes, some of the antibodies we have in 6-month-old babies. And yet we have autoimmune causes in people who are 90 years old. CJD, the youngest sporadic patient I'm aware of is 12 years old. The oldest is 96. But the peak age is in the early 60s. That's the most common age for CJD and probably for most rapidly progressive dementias. It's kind of in that early 60s. But I have patients in their 20s, their 30s. When they're that young, 20s, 30s, often it's a genetic disorder, an inborn error of metabolism, and they can be a little harder to diagnose. Sometimes we have to do more complicated urine, blood, spinal fluid analyses to detect inborn errors of metabolism.
And so what would you do to treat someone with any form of RPD? What is I know.
Yeah, great question. It depends on, first we got to find the cause.
Right.
We don't treat until we know the cause, because a treatment for one type of disease might actually harm another. So you need to have the right cause. An example would be steroids. Autoimmune diseases often respond to high-dose steroids. But if you have an infection, certain infections, or if you have a lymphoma, and you give that patient steroids, you could really worsen the infection. If they have lymphoma, the lymphomatous cells are degraded by steroids. They break down and are destroyed, which makes it harder to make the diagnosis because you don't have the cells you need to make the diagnosis. So you delay diagnosing the lymphoma, you delay the treatment for that patient lymphoma. So we don't like to treat randomly unless the patient's really declining, unless we have some idea of what the diagnosis will be, unless we're pretty confident that the treatment won't be deleterious, won't be harmful.
Yeah.
But the key to treatment is finding out what the cause is. And sometimes there won't be a treatment. CJD, Alzheimer's, we don't have a treatment. We can treat some of the symptoms, but we're not generally changing the course of the disease. We're not curing the patient, at least as of today in 2021 when we're doing this interview.
So is there anything kind of on the horizon that we can be hopeful for with regards to this?
I am hopeful. So we've already done, there've already been about 4 treatment trials for prion disease. Unfortunately, all of them have failed to show an improvement in survival, but some of them have shown to have some effects in the laboratory, and maybe that those medicines in combination with other medicines might be helpful. We're also looking at genetic ways of treating some of these diseases now. So there's therapies for a disease called spinal muscular atrophy. That's a disease of infants, newborns, and usually they don't live until past the age of 2. And what we're doing now is we're giving small pieces of artificial DNA into the spinal fluid. These are called antisense oligonucleotides, or ASOs, and we're blocking the abnormal protein from being formed. And we give this treatment through the spinal fluid, through a lumbar puncture or a spinal tap. And we do them every couple of weeks or every couple of months. And we have patients who are walking who would never have walked before, who are surviving past the 2-year time point.
Wow.
These types of studies have now been done in animal models in prion disease. And we're thinking about doing these in hopefully the next year or 2, maybe, unknown yet, in humans with prion disease. It's possible. So I'm optimistic about some of these treatments. For Alzheimer's disease, there have been more than 40 medication trials that have all failed. But some of them, when you do secondary analyses, look like there might be sub-cohorts that might respond to treatments better than others. So I'm optimistic about those. And then there are new types of treatments that we're looking at for some of the neurodegenerative diseases that might hold promise as well. And then there are viral vectors for gene therapy, where we're actually injecting or putting in new genes into the brain to help ameliorate either block the abnormal process that's going on, or to replenish a gene that's deficient, that's too low, by supplanting that. So there are lots of things going on now. I did my PhD 30 years ago on human gene therapy, and now I'm actually in the clinic applying the techniques from what my PhD was on 3 decades ago. So there can be a long time course between what we do in the lab and what gets to the patients in clinic. But I'm more and more hopeful all the time.
Well, I think that's probably a good note to end it on. We did have one question here in the comments. You kind of touched on this earlier, but which autoimmune diseases can cause rapid onset dementia, or is it kind of many different kinds?
No, it's a great question. So usually the systemic autoimmune diseases, rheumatoid arthritis, lupus, those usually do not cause rapidly progressive dementia. So the systemic rheumatologic diseases, Sjogren's, those things, there have been case reports of those causing it, but I even doubt some of those case reports. There might be some cases, but the vast majority of autoimmune causes of rapidly progressive dementia are antibody-mediated causes. And those would include LGI1 encephalitis, Caspr2, NMDA receptor, AMPA receptor. So these are proteins that are either part of the receptor on nerve cells, or sometimes they're on the surface of nerve cells. Sometimes they're in the synapse, the connection between 2 adjoining nerve cells, the synapse. Sometimes they're inside the cell. There are proteins or targets inside the cell, and antibodies against those can lead to various neurological syndromes, seizures, neuropathies, death of sensory nerve cells, general blockade of certain neurotransmitters, and which are distributed in different parts of the brain, such as the NMDA receptor. And those can lead to various neurologic syndromes, including encephalopathy or a form of rapidly progressive dementia. And many of those are very treatable, somewhere 80% or more recovery.
Wow. Okay, well, that's a little helpful in conjunction with what you were saying earlier. But is there anything you feel I've missed that you'd like to touch on? Maybe a misconception or?
No, I think we've addressed many of the things. It's, in a short 30-minute conversation, it's hard to capture everything.
Absolutely.
But I think in the time we've had, I think we've really touched on the key points in a very nice way.
I agree. I couldn't agree more. And you've been extremely thorough, and I really appreciate your time. Thank you.
Thank you.